Well, good evening, everyone. My name is Ronald Anglade. I am a board certified urologist here at Georgia Urology. Been here for many years, and my area of expertise and fellowship training is in sexual dysfunction and sexual medicine, as well as in male infertility. Spent a good portion of my training and research years looking into some of the genetic causes of male infertility, as well as the treatable causes of male infertility. So, in general, people have the misconception that fertility is really a woman's issue, and it isn't. I generally don't like to refer to it as one person or another because it really affects a couple. So, when we talk about fertility, the statistics would tell us that one third is male factor, which is what I mostly deal with. Another third is female factor, and the last third is a combination of both factors, male and female. So when we do have a couple that's having difficulty conceiving or having a child, it's important that we don't ignore one or the other. And also, we take a comprehensive look at both parties involved and see what we can do to help achieve the goal, which is essentially to have a child for a loving couple. When I first meet a couple and talk to them about their fertility issues, one thing we like to do is try to establish whether or not this is um, an issue where there's an obstruction, which is blocking the ability of sperm to make it into one's ejaculate or into one's semen, right? Or is it non-obstructive? So let me be more specific about that. A lot of people think that if they are producing an ejaculate, they are producing sperm. Now, that is a misconception because a lot of men will ejaculate and have very little or no sperm in their ejaculation. So, for instance, when I perform a vasectomy on a man, it very rarely changes the amount of fluid they make when they ejaculate, but we remove the sperm from the ejaculate so that they are essentially infertile. And in many instances, that can occur with a vasectomy. Sometimes that can occur through trauma. Some have an injury to the pelvis. And there is also a specific condition called congenital bilateral absence of the vas deferens, where men can be born without vas. And they produce sperm normally. They have sperm in the testicles. The testicles function just fine. But there is no way and there is no conduit for the sperm to get from the testicles to the ejaculate. And so then they're sterile, right? But there is another option, and that's where men make very little sperm. And so they may have an ejaculate, they have the tubing to bring sperm to the ejaculate, but when you examine the ejaculate, there's very little sperm. And that's what we call non-obstructive azoospermia or non-obstructive oligospermia, low sperm counts. And even though a man may ejaculate and have very little sperm, it doesn't necessarily mean that there is not sperm to be found. Sometimes we can find even very small amounts of sperm in the testicles and in the tubing surrounding the testicles that can be used for fertility and for the purposes of in vitro fertilization, specifically to help a couple still conceive a child of their own genetic material. In general, when I first meet a couple and we start talking about their fertility journey, we like to get some ground rules, right? First, I like to make sure that they're able to have intercourse normally. They're able to um, engage in sexual activity on a routine basis, that the man is able to reach a climax and actually have an ejaculate. And those are very important first steps because some patients may come in and the man may have significant sexual dysfunction. Maybe he's had, prostate surgery or a spinal cord injury or something like that, that can preclude them from conceiving, sort of naturally. So once we get those initial factors out of the way, then I ask about frequency of intercourse, how long have they been trying? Are there other factors that are making it difficult for them to conceive? And once we've established that a couple has been trying for at least 6 months and been actively trying for 6 months, then we start saying that that truly may be an issue with fertility. Another thing that I bring up, and it's a factor in life now, that a lot of people are delaying the time in which they want to try to have a child and try to start a family. So if you're an older couple, maybe in your mid to late 30s, and you're having difficulty conceiving, usually I recommend an evaluation definitely within the first 6 months and not a year, which we sometimes wait for a younger couple. So if you show up in the first 6 months go by and you're having difficulty conceiving, that's when we'll really start an evaluation. You do obviously for physical examination, check some blood work, see if there are any obvious family factors that may play a role. Was the gentleman have any kind of significant testicular injury? Was he on chemotherapy? Did he lose a testicle for some reason? Those are, initial factors that we like to rule out. Now, once you get past those initial factors, the main test that we use to determine one's fertility is a semen analysis. And we recommend that you collect at least two semen analyses, which are separated by at least a week or so in time and are collected after at least a 2 to 3 day period of abstinence. And if the semen, and if both semen analyses are consistent and show that we've got an issue, and those issues may be low sperm count, they may be poor motility, which is the movement of the sperm, can be poor morphology, which is the appearance of the sperm. Those are issues that we try to address and see if we can correct. On the physical examination, I try to assess for testicular size. I try to assess for any physical abnormalities. I definitely make sure if I can palpate the vas, those tubes that carry the sperm. I make sure there's nothing like a varicocele, which are distended veins that can affect the testicular function. I'd like to describe varicoceles like having varicose veins in your scrotum as opposed to in your legs. And those veins can put pressure on the testicle and affect the way it functions and produces sperm. So those are sort of the initial physical findings that we have, right? And so if at that point I find a guy's got a pretty normal physical examination, I can feel his vas, his testicles feel pretty normal, there's no masses, tumors, or what have you, we look at the semen analysis to see what we have. And again, if semen analysis is pretty reasonable, then we suggest continued attempts at fertilization or consideration to some of the assisted reproductive technologies such as IVF or IUI. Another option or another avenue that we evaluate is hormones, right? So one thing that I always like to make sure of is that men who are infertile are not abusing steroids, not on a bunch of testosterone, not on chronic painkillers. There are different medications can affect one's fertility. So once those sort of things are evaluated and sort of addressed, the next thing we look at is the presence of sperm in the ejaculate, yes or no. Now, if there are very few or no sperm in the ejaculate, the term that we use for that is what's called azospermia. Okay, and if there is azospermia, again, we make the delineation. Is it obstructive azospermia, where the tubing is there, where it's blocked either from a vasectomy or trauma to the pelvis or something of that extent? Or is it non-obstructive azospermia, where the tubing to transport the sperm is there, but unfortunately, um, we don't see sperm in the ejaculate, right? Once we get to that sort of understanding, I always like to also order some genetic testing because we know that there are certain genetic abnormalities which lead to poor production of sperm. So a lot of men will have normally functioning testicles. So they'll make testosterone normally. They'll virilize real well. They have good size. They have good testosterone levels. But for a genetic reason, and specifically, they're called Y chromosome microdeletions. And what those are that on the Y chromosome, which only men carry, we are missing some of the genetic material that is necessary to produce normal amounts of functioning sperm. And depending on the deletion, whether it be a very small deletion or a very large deletion, there are varying situations in which we can obtain sperm from the testicles. So we get the genetic tests, make sure there's nothing there that we can act upon. And if everything else fails and we're still at a point where we don't have a good explanation as to why there's no sperm in the ejaculate, we will proceed with a testicular biopsy or obtaining testicular tissue to see if there are sperm within the testes themselves. There are multiple procedures that urologists will do to find sperm. Some include testicular mapping, where you'll take a small needle into the testicles, obtain aspiration. You'll take some fluid from the testicles to see if you find sperm. There's something called a epididymal sperm aspiration, where particularly for, let's say, a gentleman had a vasectomy And because the vas is obstructed, now the testicle becomes very full and the epididymis becomes full of sperm, where we can aspirate sperm from the epididymis. And those sort of aspiration procedures are relatively non-invasive, requiring very little anesthesia. They're quick turnaround, and patients are really able to return back to normal activity within a very short period of time. Personally, what I like to do is something called the testicular sperm extraction. And that's where under local anesthetic, I may make a small incision in the scrotum and obtain testicular tissue, which in which we can usually find sperm. Okay. And so those are some of the more common procedures done to find sperm in the testicle. The other thing I will mention is that depending on some of the other blood work we obtain, particularly the hormonal blood work, it will give us an idea as to whether or not there's a high likelihood, a moderate likelihood, or a relatively low likelihood of actually finding sperm in the testicular tissues. And the one thing I will mention to my patients is that if we do find sperm in the testicular tissues, those are sperm that would have to be used with reproductive technologies, either IVF or an even more intensive procedure called ICSI, where the sperm are actually injected into individual eggs. So once we get to the point where we're looking at doing testicular biopsies and sort of obtaining sperm from the testicles themselves, those patients generally are looking at doing in vitro fertilization in one way or another. The one caveat to that is, if let's say, we can identify that there's completely normal sperm production within the testicle, and maybe there was some sort of obstruction, either from an infection or an injury to the testicle. There are some times where we can reconstruct the connection between the vas and the testicle to allow for normal return of sperm into the ejaculate, but that's relatively few and far between. In general, there is what we call a TESI, which stands for testicular sperm extraction, and that's a procedure where, generally under some local anesthesia and sedation, a small incision is made in the testicle, and we take some of the testicular tissue from the testicle, and we can look at it under a microscope and identify sperm, which can be used for in vitro fertilization. Now, in rarer cases where, let's say we did a testicular mapping procedure and found isolated areas of sperm where very few sperm are produced, another procedure that can be done is called the microdissection TESI. And that is where, under my operating microscope, the testicle can be essentially opened up, bivalved, split in half, and using very precise instruments, go through the testicular tissue almost tube by tube, looking for the presence of sperm. Now, again, that's very technically difficult, and it's very time consuming, but in some cases it is fruitful because we can find even very small numbers of sperm which may be able to produce a conception. Now, those are basically the two types of testicular sperm extractions: the microdissection TESI and the sort of standard TESI. Now, as I may have mentioned before, there's what's called the testicular sperm aspiration, where with the mapping technique of placing a small needle within the testicles, we can obtain fluid from the testicle itself to hopefully isolate areas of limited spermatogenesis. So within one's testicle or within both testicles, you might find areas where there are just limited pockets of sperm production, and that's how a testicular mapping procedure can be helpful. When we talk about some of the success rates for some of the procedures that I've discussed, particularly the most sort of labor intensive, the microdissection TESI, the microdissection testicular sperm extraction procedure for non-obstructive azoospermia, when you look at some of the studies, success rates range from about 50% to 75% or higher. So those, for the patients who really believe that there's not much else that can be done, if we can obtain sperm in 75% of these patients, it's a wonderful opportunity for them to still produce children of their own genetic material. And when I say their own genetic material, I like to be very specific about that because, again, there are many ways to have children, many ways to have families, right? Many ways to have sons and daughters. which don't require them to be of your own genetic material. But for those patients where it's particularly important, then we can go, that route and try to be as aggressive as we can in finding those solutions. Um, but I've had, multiple patients where we've identified either genetic issues such as Klinefelter syndrome or cystic fibrosis, where even though we've been able to find sperm, the couples have made decisions where they don't want to use, the husband's sperm and use either donor sperm or adoption or other ways to have families. So I always like to explain to my patients that even if we're unable to find sperm, we are successful with our most advanced technologies, that, having a family is still a very viable option, and they should be encouraged by that knowledge. In my practice, I'm also very happy to report that we've had very good success with vasectomy reversals. Um, I was classically trained to do a microscopic vasectomy reversals in fellowship, many years ago. So when we talk about vasectomy reversals, the most, um, I guess, key factor to success, or the most important factor to success, is the time of the vasectomy and the obstructed interval. How long have you had your vasectomy? Now, whenever I meet a gentleman, I ask, and we do a consultation for a vasectomy. A couple of questions I always ask is questions about the partner. Who is the partner in this relationship? Who is it that you want to impregnate, right? Because that's very important. So if I have a gentleman who's had a vasectomy maybe a couple of years ago, but his partner is also in her late to mid 40s, a lot of times it doesn't make sense to do a vasectomy reversal unless we're fairly confident that the partner would be able to get pregnant through intercourse. Because I'd hate to take a gentleman through a relatively, not a particularly difficult operation, but a 3-hour operation nonetheless. And then he has a vasectomy, has sperm, but then his wife's going to need IVF anyway. So I always like to make sure that I have a good understanding of who the partner is. I've had couples who have had a vasectomy and changed their mind. And I love that because I know that if they've been able to have a child together, the two of them, that if I can restore sperm back to the ejaculate, that there's a very good likelihood that they'll be able to have a child as well. One thing I always like to explain about vasectomy reversal is that for me as a surgeon, my success is returning sperm to your ejaculate. And having a child is the secondary goal as I see it. But again, from the patient's perspective, they want to have children. So the vasectomy reversal is is done for that purpose. But again, it's the return of the ejaculate of sperm to the ejaculate is what we can hopefully control on our end. Having a child is a multifactorial event. So a lot of times, once the vasectomy has been completed, sperm's back in the ejaculate, I'm still not sure if we won't need to do additional work to help you have a child. But specifically to talk about the vasectomy reversal, first thing I like to tell patients is that it's definitely more invasive than a vasectomy. Vasectomy, usually an office procedure, takes, 15 to 20 minutes. Very small incisions, home the same day, a little ice on the scrotum, some painkillers, and you're fine. Vasectomy reversal is not much more than that, but definitely more labor intensive. It's about a 2 to 3 hour operation. It requires incisions in the scrotum. Again, not particularly large. But what we do is expose the vas and bring basically the two cut ends together. I always do my vasectomy reversals using a surgical microscope. So we're under 40x magnification, and that allows me to bring both the inside and the outside of the vas tubes together. So we do what's called a two-layer anastomosis to bring both together to maintain the continuity of the vas, both on the inner sort of lumen and the outside of the vas. It's important that we bring that together to make sure there's no tension on that anastomosis, so that connection is not pulled apart by just running, jumping, lifting, or what have you. I also ask that my patients after the vasectomy do not ejaculate for at least 3 weeks, because anytime you ejaculate, it puts pressure on that connection. We want that connection to heal without pressure so that we make sure we have a good connection. However, from a pain standpoint, it's really not that bad. A couple of painkillers usually will take care of it. I recommend that my patients ice and elevate their scrotum after the surgery itself. And I usually suggest that if the vasectomy has not been more than 5 to 10 years old, there's a very high likelihood, 90% or greater, return of sperm to the ejaculate. So I think for many couples, it's a very good and reasonable way to reestablish sperm to the ejaculate, giving them a good chance at having a child through intercourse. So when we discuss couples who come in or come to see me or my colleagues about their fertility journey, right? We first like to get initial information, make sure you're healthy, make sure, any other medical conditions are addressed, diabetes, high blood pressure, those kind of issues are addressed. From my standpoint, I want to make sure that my men are healthy and taking care of themselves. And once we kind of establish that, then we can kind of look at what risk factors do they have for fertility. Again, I always ask a lot of questions about their hormones and testosterone usage, alcohol usage, opioid usage, and we try to make sure those things are not factors. We check for family history of fertility issues, birth history, testicular injuries, those obvious things that can affect fertility. And once sort of the obvious questions are asked and answered, then we get to the testing. The testing will include a thorough physical examination, a full blood work evaluation, including hormones, and a semen analysis, which is necessary. Again, once those things are all done, then we can identify what's going on, particularly with the use of the semen analysis. If the semen analysis is normal, then that's sort of our rubber meets the road test, and we say, okay, let's proceed. You've got a normal semen analysis. Let's see what else we can figure out. But if the semen analysis is abnormal, then there are ways we can try to improve the semen analysis, either through vitamins and sort of lifestyle changes, hormonal medications we can use to boost testosterone production and sperm production. So there are things we can do medically. If we find out that the patient is truly azospermic or severely oligospermic. So by definition, azospermia is no sperm seen in the ejaculate. Oligospermia is less than 10 million sperm per cc of ejaculate. Severe oligospermia is less than 5 million sperm per cc of the ejaculate. And if we identify those issues, that's when our evaluation becomes a little bit more aggressive. And then we start to look at the physical changes. Are we dealing with a gentleman with an obstruction? Are we dealing with a gentleman without an obstruction? And go down the roads towards, do we need a testicular biopsy? Do we need to evaluate the testicle, which is the source of the sperm, and so on and so forth? Are there any surgically correctable issues uh, with the reproduction, such as a varicocele or the obstructed ejaculatory duct or something of that extent? So once those are addressed, then we say, what is the potential for this couple to have a child, and how can we assist in that way? So I tell my patients when they come in to see me that in the vast majority of patients, we can find something that we can correct and help them to have a child. And that may be done naturally through something called IUI, and that's where the sperm count is relatively low, but not so low that taking the sperm and putting it directly into the woman's womb would not be effective. So I'll tell you a little bit about that. We usually say that natural conception can occur with a semen analysis which reveals a sperm concentration of greater than 10 million per cc. And if there's less than 10 million per cc, it's unlikely that you'll be able to get pregnant through intercourse. If it's less than 5 million per cc, that's what we consider severe oligospermia, and that's where we have to look more towards the testicular biopsy, in vitro fertilization, so on and so forth. And between those numbers, those are candidates that generally may benefit from what's called intrauterine insemination, and that's where the ejaculated sperm can be collected, can be washed and prepared, and put directly into this female when she's ovulating. And in many instances, that may result in the pregnancy. So, um, one thing that I like to do when I speak to my patients, sort of try to make that stratification. Do I think that you've got enough sperm to get pregnant through intercourse? Do I think we need to really look at IVF or IUI? And once we can counsel in that way, that may help me make appropriate referrals to the doctors that I know who are reproductive endocrinologists who take care of the female partner so that we can work as a team and help our couples get pregnant. So the last thing I'd like to say is that even if you're having difficulty getting pregnant at home, don't waste too much time trying without at least an initial evaluation. And again, in my mind, that's if after 6 months a normal, otherwise healthy couple is having difficulty, then you should at least seek an initial evaluation, knowing that at a year, most people will still conceive on their own. But if you're an older couple, have any known medical conditions, if you have any thought that you'd have difficulty conceiving, then the earlier you can sort of answer those questions, get an evaluation, the better. Well, again, thank you so much for your attention. I hope that I've been able to share some of my thoughts and some of the things that we can offer here at Georgia Urology and as doctors who are specially trained to deal with male fertility. I appreciate your time and your attention and look forward to hearing from both myself and Dr. Kapati and some of the other physicians in our practice who find that, male fertility is very rewarding. And one last thing I'd like to say to my patients who may be watching this, who I've treated before or looking for a doctor to work with in their attempts to have children, is some of the most gratifying work that I do is helping couples, achieve pregnancies and bringing home children. That's something I really enjoy doing. And if trust me with your care, I'd be glad to help along that journey as well. So thank you.